Good morning. Oh, actually, it's good evening over there.
Yeah.
We're a little bit time delayed, but welcome everyone. So thank you. We'll go ahead and get started. Just in terms of background, I do speak for Pure Encapsulations and use these products significantly in my practice. I really enjoy the purity of the brand and knowing that if I'm recommending herbal products, that they have in them what they say they're supposed to have in them. And that's, of course, very important for the practice of medicine. So my practice really focuses on weight management, but we really focus on the metabolic effects of weight and why these metabolic effects make it hard to lose weight. But in the United States, unfortunately, two-thirds of adults are overweight or more. They're actually saying 70%. And losing weight is actually difficult. My patients will say, I eat well and exercise, but I gain weight instead of lose. Another very common thing is women who will say, since menopause, I haven't been able to lose an ounce, and in fact, I'm gaining weight. Or they'll say, I know what to do, but I just don't do it. I just can't do it. I have all these cravings. And that really is a significant issue for people. They crave starches and sugars even though they have really promised themselves that they would not. And they end up feeling that they must have some kind of emotional problem that's getting in the way of being successful. So we know that weight issues are multifactorial. There's definitely a genetic predisposition, which we're going to talk some more about. Somebody's body type, the distribution of where they carry weight, lack of time for self-care, which unfortunately is very, very common in our busy life. But the busy life also leads to stressful eating, emotional eating, and the like. We also know that medical conditions like thyroid, underactive thyroid is an issue, and certainly medications that are given for the medical issues that develop because of the weight can further increase weight. Orthopedic issues are common, hormone changes, as I mentioned, like menopause, and even the natural process of aging increases weight for most people. We'll speak about nutritional deficiencies that occur and affect weight management and metabolic dysfunction. But specifically in this webinar, we're going to dive more deeply into what is called insulin resistance, or what I call the MD factor. MD factor standing for metabolic dysfunction. So medically, we know MD factor as insulin resistance. But this is a difficult concept for patients who, when they hear insulin, they think of needles and syringes and diabetic. But what I tell people is that it's a very common and often overlooked metabolic condition that makes gaining weight easy and losing weight difficult. And so to get the whole words of insulin out of it, I call it the MD factor when I'm talking to patients. But the real take-home message of this webinar is that identifying insulin resistant at an early stage or any stage, because many patients will come in an advanced stage of insulin resistance, and we want to treat them anyway. But we want to identify it and treat it aggressively with diet, lifestyle, supplements, and medications if we need to go that far. It has been the cornerstone of my medical weight loss practice and my metabolic correction practice. So with regards to insulin resistance and medical conditions, we know that if somebody has insulin resistance, they are more likely over time to develop high blood sugar, high cholesterol, what is called the metabolic syndrome, which is just an advanced form of insulin resistance or MD factor. Of course, diabetes, again, an advanced form. Fatty liver, which is fat deposition in the liver, is a consequence of insulin resistance, as is heart disease, stroke, many types of cancer, probably at least 12 or 13 have been identified. Infertility in young women due to polycystic ovarian syndrome, and then, of course, overweight and obesity. So the diseases that affect the advantaged world in terms of people who actually have money and they live in a modern lifestyle, these are the medical conditions that really affect health and longevity. We're much better about treating infections than that, but the majority of our issues are coming from metabolic conditions which have a very strong tie to insulin resistance. So I want to just focus on this graphic for a little bit. What this shows is a normal cell and an insulin-resistant cell. On the left, you will notice that glucose is depicted in the red, insulin in the orange. And on the surface of the cells are these receptors that look like a little bit of a tree. In order for glucose to enter our cells and give our cells energy, insulin has to attach to the receptors, the glucose portals have to open, and then our cells have energy. So you see in the left, there's energy inside the cell. When we go to the insulin-resistant cell, what we'll notice is that there's far more glucose outside of the cell. And it looks like there might be less insulin, but there's actually more. You will notice that these insulin receptors, they're far fewer. And this is to artistically depict that these insulin receptors, while present, do not work properly. So insulin attaches, glucose is able to enter the cell, but there's far less insulin entering the cell. The cells are starved for energy. In addition, there's all this glucose outside of the cell, and the body has to do something with all of this glucose. What the body does with all this glucose and insulin is store it as fat, primarily visceral fat. Now, a lot of the symptoms of insulin resistance, because there indeed are symptoms, are related to that same picture. People will say that they're craving sweets or starches, but that makes sense because there's not enough glucose inside the cells. Even though there's plenty of glucose in the bloodstream, it's not getting in our cells. And our cells need glucose, they need energy, so we get all sort of hormonal signals to crave sugar. Get me sugar fast, get me starches fast. What we also find is with all this glucose around and all this insulin around is eventually blood sugars will drop. And unfortunately, they drop what we call precipitously. They drop quickly, which can lead to energy plummets, which a lot of people will experience after a higher carbohydrate-containing meal or at 3 o'clock in the afternoon after they've had lunch several hours before, just very, very exhausted. Some of my patients will say that they're not hungry in the morning, and that is also explained by that same photo. If somebody is insulin resistant, in a fasting state, they have high insulin levels because the body is dysregulated. It's releasing insulin all the time. And normally, insulin is only released after a meal. But you'll see in the case studies, it's not uncommon that there will be patients who have very high levels of insulin in the morning. And when your insulin is high, you're not necessarily hungry. But then patients eventually eat sometime later in the day, and because they have so much insulin on board, their blood sugar can drop precipitously, or they find that it's very hard to stop eating. Symptoms of brain fog after a higher carbohydrate meal can also be explained by the effect of too much insulin, because higher level of insulin allows sodium to actually enter the cells of the brain and cause a mild swelling. So people, when they feel foggy after a higher carbohydrate meal, that's what's going on. And then a very common symptom is this difficulty staying asleep. My patients can say that they fall asleep, but they'll wake up at 2 o'clock or 3 o'clock in the morning. And usually that can be made worse with diet, such as if they have a very high carbohydrate meal, one that has a lot of rice or noodles, and if they were to add alcohol to that meal, many times that will really disrupt the sleep. And what is happening is that in the early morning hours, there's a reactive relative hypoglycemia, meaning blood sugar is dropping, certainly not to a life-threatening state, but enough to wake patients up and really disorder their sleep. So in the United States, which of course is not Hong Kong, but it's very, very common to find insulin resistance. So 90% of the women I saw over the past 3 years and almost 100% of the men had obvious evidence of insulin resistance when we did blood work testing to test for it. So it's very, very huge here in the U.S. And the parameters that we're looking for a positive result are glucose, hemoglobin A1C, which is your 3-month glycated hemoglobin levels to show blood sugar regulation, triglycerides being elevated, low HDL, which is what we call here good cholesterol, and an elevated fasting insulin. We're able to check that in the fasting state, and when we see evidence of abnormalities in these 5 markers, we can say definitively that this patient has insulin resistance. And again, we would like to ideally pick it up before it manifests in high blood sugar. So there's many causes of insulin resistance. And we'll talk a little bit more about genetics because people of Asian and Hispanic descent have a much higher incidence of insulin resistance. Also, where we carry our weight, the visceral fat distribution, really increases insulin resistance because of the increased free fatty acids that affect the liver and the creation of glucose from the liver. It actually will reduce the clearance of insulin from the liver, and insulin resistance increases. Normal aging contributes, medications, menopause, and vitamin deficiency. So with regards to insulin resistance, what's very important that type 2 diabetes develops in East Asian patients at a lower mean body mass index compared to those of European descent. So at any given basal body mass index, East Asians have a greater amount of body fat and a greater tendency to deposit that fat in the abdomen, where it is more metabolically adverse and contributes to lipotoxicity and insulin resistance. So we actually see that diabetes will develop at a much younger age, and it's characterized by early cell dysfunction in the setting of insulin resistance. So in the U.S., when we have somebody of Asian descent, whereas someone of a European descent, we might say, okay, they're overweight at a body mass index of 26. However, in studies of Hong Kong Chinese patients, there was a highlighted risk that the diabetes and other cardiometabolic risk factors increases at a BMI of 23. So that's significant. Even though there may not be a lot of pounds of weight, that weight is all in the abdomen, and it's causing this insulin resistance. In the United States, we see that, under the age of 40, insulin resistance is about 20% for men, 16% for women, but it definitely increases with age. And we're seeing here in China, Taiwan, 20% of male patients with metabolic syndrome, again, an advanced form of insulin resistance. As we look at this, I say, okay, 20%, 30%, nothing like the U.S., but realize that metabolic syndrome is an advanced form of insulin resistance. Still too many people. The good news is insulin resistance is easy to diagnose and treat, and hopefully from this webinar you'll get some good pointers on that. So in order to test for it, we look for a physical exam, and one of the things that's very, very simple and powerful is the waist circumference. Being able to measure that, with a tape measure and seeing that, okay, the waist circumference in the U.S. values for women is like more than 35 inches, or for men 40, which of course you guys all probably use centimeters, but it's still not perfect. I looked at studies years ago that took patients of Asian descent and European descent and did CAT scans through their body and found that at any given weight or waist circumference, people of Asian descent had much more visceral fat. So even though their abdomen may not be large, there's just more fat lurking around the liver in the visceral areas. What's probably more useful is to do lab work, looking at the lipid profile, specifically paying attention to the triglycerides and the HDL, the glucose level, and we do that with a simple chemistry panel that also tells us people's liver and kidney function, and we often do find evidence of elevated liver functions, showing that there's fat depositing in the liver. We check a fasting insulin level, so an insulin level in the morning before eating, and the hemoglobin A1C to see what the blood sugar regulation over the past 3 months has been. If we need to, we can do a glucose tolerance test with insulin levels. We usually don't need to do that. And we always do, not if needed, tests for vitamin levels, vitamin D, magnesium in the red blood cell, and B12. We find that these levels are often low and they contribute to insulin resistance. So with regards to treating it, we treat it with primarily diet and lifestyle. What we find is really important is to lower the carbohydrate intake of meals while making sure there's enough lean protein so that there is not muscle loss in the process of fat loss. We go ahead and recommend exercise, nutritional supplements, and if we need to, medications. So with regards to metabolism correction for weight loss, we want to have a meal plan that is higher in protein. And there's several studies that show that the diets consisting of 25% protein, which in the U.S. is higher than what is considered the standard American diet. But those are more associated with weight loss because there's a higher 24-hour energy expenditure, better protein balance. What I find is really the key is being able to lose fat while not losing protein and muscle mass. Because our body does not have storage capacity for protein. It only exists in our muscle tissues. If our patients are dieting for the purpose of weight loss and they are not having the regular intake of lean protein, they will actually break down muscle tissue in the process and lose muscle tissue, which causes more loss of metabolic rate. We do know that protein is the highest and has the most prolonged thermic effect of the macronutrients, meaning that eating protein helps us burn more calories. And in a couple studies here, a 12-month study of 50 subjects, those consuming 25% of the diet from protein lost nearly twice the weight of the group consuming 12%, and just seeing the improvements with increasing protein. Also importantly, the higher protein diet was associated with a 10% greater reduction in abdominal fat distribution. Now, when we talk to our patients, because we do in-depth dietary counseling, we don't tell them, have 25% of your diet from protein. Nobody knows what that means. We don't eat protein. We eat food, and food contains protein, and food contains carbohydrate. So what we actually ask our patients to focus on, and we discuss it in the MD Factor diet, is aiming for 25 to 35 grams of lean protein at breakfast, lunch, and dinner when we're trying to resolve metabolism dysfunction. If we have a patient who needs some snacks, they're very hungry, they're craving a lot of sugars and carbohydrates, we will aim for 10 to 15 grams of protein in 2 to 3 snacks over the day. Usually that would be the men who might have the more snacks. But it comes down to about 100 to 120 grams per day for women and 120 to 140 grams per day spread over the course of the day. And what's important is the regular intake of lean protein. We just don't want our patients to eat a huge amount of protein at one meal because that's not the way the body utilizes it. In terms of understanding what 25 to 35 grams of protein is, it's about 4 to 5 ounces of chicken or fish. That's a serving size about the palm of most people's hand. We're not asking people to eat 16 ounces of meat or an incredible amount of protein, but we want the protein spread throughout the day. Because if we exceed the 25 to 35 grams of protein for an individual at a meal, the body can only utilize about 25 to 35. The rest is actually converted through biological processes to glucose and fat for storage. So the key is not just lots of protein. It's adequate protein, but we want to spread it throughout the days. Now, I'm not really sure what the current diet is like in Hong Kong, if there's a lot of adoption of Western diets, which isn't good. But in the U.S., what is common that in the morning, breakfasts are very high in carbohydrate. A lot of cereal, lots of grain. There's not very much protein unless somebody has bacon and eggs and sausage, which is then very fatty. We've really tried to move away from fats, but then very, very high carbohydrate breakfast foods, which aren't good for somebody who has metabolism dysfunction. In the US, there's also maybe a little protein at lunch, but what happens is there's a large amount of protein eaten in the evening hours with dinner. So not enough during the day and too much at night. So spreading it out throughout the day makes a difference. And that's where protein powders could be useful for our patients. Preparing adequate protein levels for breakfast and lunch might be challenging when people are working or they're not used to eating, or in the morning, like they're not hungry in the morning. Sometimes using a protein powder can be helpful, but well-sourced protein is expensive, and many of our patients have allergies to dairy or soy. They're difficult to digest and cause all types of problems. Many of my patients will use a protein shake like the Pure Lean protein lines in the morning to help them meet their nutritional requirements. Now, in terms of the different types, there are several. There's the Pure Lean and the Pure Lean Basics. The Pure Lean one is a rice pea-based protein, and it actually has a vitamin core in it. So patients can get the benefit of like a multivitamin within this one. Pure Lean Basics actually does not have the vitamin included. And I asked Pure Encapsulations to make this for me years ago because I had some patients with significant dairy allergy, soy allergy, egg allergy, who were wanting to use a shake like this maybe twice a day to be maybe a breakfast, lunch, or a snack, and I didn't want to give them too many vitamins. I'd rather be more specific and intentional as to which vitamins I wanted them to have. The Pure Lean Whey has whey protein powder in it, which of course is a dairy-based, although many people can tolerate it. Whey does have a high amount of branched chain amino acids, so it's very helpful in preserving muscle tissue in those who can tolerate whey. And Pure Lean Ultra is a protein powder that I asked Pure to formulate for my practice, based on really increasing the protein to 25 grams per serving, keeping the fiber up, keeping the carbohydrates down, but we really worked on taste. What I find is that sometimes protein powders don't taste that good, and then people end up putting fruit in it. Here in the U.S., they'll add a banana and strawberries and all of this stuff, and before you look at it, this protein shake became a 400-calorie, high-carbohydrate meal because there's multiple fruits involved. If we can actually have a protein powder that tastes good, that meets the nutritional parameters, we're actually doing something. So talked about all of those. Again, the Pure Lean ones, regular are pea, rice, and chia, whereas Pure Whey is undenatured whey protein. And all of them are going to provide the nutrient requirements. The highest one from protein is going to be the Pure Lean Ultra at 25. The other ones have about 15 grams of protein per serving. Some of my patients may use 2 servings of that if they prefer the flavor to meet the requirements of 25 to 35 grams at a meal. So with regards to metabolism correction for weight loss, again, talking about carbohydrates, as we get older, our metabolism for carbohydrate declines with age, especially if we lose muscle mass, which many people do lose muscle mass with age as they become more sedentary. So everyone needs to watch the glycemic load of meals, to watch the total carbohydrate intake with the meal. And we can affect the glycemic load by pairing the carbohydrate component of the meal with protein and fat. Like, I would prefer that my patients have balanced meals than to have carbohydrates on an empty stomach. Like, for example, just fruit by itself. Even though fruit is considered a healthy carbohydrate, when it's eaten by itself, it has a high glycemic load because it's all carbohydrate with no protein and fat to balance the absorption and how the blood sugar rises and then how the insulin rises and then falls. We do find that if you have more than 20 grams of carbohydrate at a meal, the body requires insulin for disposal of the glucose. So some of my patients who have severe metabolic dysfunction, we will create their meals to not exceed 20 grams of carbohydrate at any meal. Now, you can have a wonderful, healthy meal and not exceed 20 grams of carbohydrate if we're eating primarily lean proteins and lots of vegetables. When we add a lot of grain and starches and fruits, then it's very easy to exceed the 20 grams of carbohydrate. Patients with lesser degrees of insulin resistance can tolerate more carbohydrate. So the challenges of eating a low carbohydrate diet, especially in the U.S., is that we are so used to it. There was a lot of subsidizing of grains in our economic development, so grains are cheap. They're in all of the meals that are convenience at restaurants, things that are simple. So it does require some work and some planning to get people on an intentional lower carbohydrate diet. But again, if we stick with more vegetables, lean protein, it is not that difficult to do. With regards to fat, there's a lot of talk, at least in the U.S. right now, about fat, that, we've really messed things up, that, we shouldn't have been concerned about fat, having fat is good, et cetera, like maybe going low fat and high sugar was a very bad thing for what's happened in the U.S., and now there's all this obesity. However, I find that, fat still matters. Fat is very calorically dense. It can be very inflammatory, especially if it's saturated fat and trans fats. We want our patients to get their fat more from the monounsaturated and the polyunsaturated fats like olive oil, avocado. We want them to minimize corn oils and those types of oils because they're present in processed foods. But fat still matters. Sometimes what happens when people try to follow a low carbohydrate diet, they just end up eating a lot of fat. And a lot of fat doesn't help people lose weight, especially women. With regards to metabolism correction, I also find that fiber is very, very useful. Because many of my patients will say, I'm not hungry until I start eating, but then I can't get full. And then I eat past the point of fullness. So one useful thing that I found is I will recommend my patients use a fiber supplement, which is a blend of soluble and insoluble fibers prior to the largest meal, which in the U.S. is usually dinner. So my patients will take a scoop of fiber when they come home from work. They're tired. They're hungry. They'll take the fiber drink, mix it in water, and that's key. You want them to mix it in water. You don't want them to just take fiber pills. And then their stomach starts to distend a little bit, feels a little bit full. They go through the process of making and preparing a dinner, and by the time they sit down to eat it, they are able to feel fuller sooner. Many of us have gotten to the point where we're over-hungry. We eat so fast. We can consume a lot of calories, but the fiber helps. In addition, we're learning that the higher fiber intake from food or even a fiber supplement can help feed our intestinal flora, which is also important for metabolic and weight management. With regards to exercise, exercise is not as critical as diet when it comes to initial weight loss. There are many patients in my practice who can't exercise but still can lose weight. We need to focus on the meal plan. And exercise is very important for long-term weight management, so it's important regardless of what one's health is. Metabolically, exercise does more than burning calories. It activates something called AMPK and SRT1, which improves these metabolic parameters that actually helps with metabolism of carbohydrate, antioxidant status, helps with immune activity, and all of that. With regards to multivitamins, there definitely is a controversy in the United States that if you eat a healthy diet, you do not need to have any vitamins. However, in my practice, I've been checking specific vitamin levels and even extensive panels in certain patients who have a lot of symptoms. And I often find deficiencies, even in people who are eating a healthy diet. We also know that people who carry more fat are more likely to have lower blood concentrations or lower bioavailability of certain vitamins and minerals like vitamin D. This particular study that I referenced here was actually looking at Chinese women, average age of 41, who were considered obese based on their body mass index. 96 of them, placed them either on a multivitamin or a placebo for almost half a year, and recommended no change in diet and exercise. After half a year, the multivitamin group reduced body weight, waist circumference, blood pressure, total and LDL cholesterol, and had these great improvements, higher HDL, with no change in diet and exercise. So that's impressive. Now, certainly, we're not going to sit here and just recommend a multivitamin. We're going to recommend the whole thing, but I'll be presenting some more information about what nutrients are going to be important to look for. When I choose vitamins, I prefer capsules over tablets for better absorption. I only recommend hypoallergenic products in my practice because, unfortunately, a lot of vitamins and supplements, especially in the U.S., can be adulterated with all types of things. And again, if I'm giving somebody vitamin D, I want to know that's what it contains and nothing else. I think when we're prescribing high-dose supplements, which I do in my practice because I find significant deficiency, purity and quality is paramount. So I have to be comfortable with the brand, which is why I like pure encapsulation. So deficiencies of micronutrients can contribute to insulin resistance, and they also cause many of the symptoms that people attribute to aging. I find that when somebody is deficient in the macronutrients, meaning they're not getting enough protein or the right amount, or they're deficient in the micronutrients, it will cause insulin resistance and resistance to losing weight. The body doesn't allow it. So some of the commonly seen deficiency in my practice are B12, magnesium, and vitamin D. I have recently begun testing zinc, and that is also something that is substantially lower. With regards to vitamin D increases insulin sensitivity. I live in Florida where there's plenty of sunlight because the common thought is that vitamin D is made in our skin from the sun. However, as people get older, if people avoid the sun, if they use sunscreen, and if they have more body fat, the vitamin D does not circulate. It gets sequestered in the fat. Studies have shown that improving a vitamin D deficiency to the normal range can improve insulin resistance by 21 to 60% in several different studies. This is huge. A 20 to 60% improvement in insulin resistance, which I mentioned is really, really common and really important. The ideal level for vitamin D is being actively debated. Some people recommend much higher levels. Some people recommend just, something more moderate. What I think is really key is to get the vitamin D out of the deficiency level. I usually strive for a level in the U.S. somewhere between 38 and 45, which is not excessively high, but it is definitely not deficient. Many of my patients have lots of other medical conditions, so I'm just careful about the balance of everything. Another favorite nutrient is magnesium, and we check magnesium in the red blood cell of our patients. Magnesium is important because it improves insulin action, and it's a cofactor for more than 300 different enzymes. Symptoms of deficiency of magnesium are anxiety, depression, fatigue, insomnia, irritability, muscle cramps, decreased mental concentration, and constipation. And many of my patients are suffering with those symptoms. In the U.S., there is less magnesium in the food supply due to farming practices where magnesium is not returned to the soil. So I find this deficiency common in my practice. I tend to use magnesium glycinate to replace magnesium. I like this particular type of magnesium because it usually doesn't cause bowel dysfunction such as diarrhea, which can happen with other forms of magnesium like magnesium citrate. But many of my patients have problems with their bowels like constipation, and they actually benefit by having some magnesium citrate. Sometimes we do a combination of both, trying to get their magnesium levels to the normal range, but also normalizing bowel movements for detoxification. Vitamin B12 is very important for energy and metabolism, And levels are frequently low due to aging, lower stomach acid, which occurs more with age. But in the U.S., there are medications that block the absorption of B12, like proton pump inhibitors or metformin, which is used to treat diabetes and metabolic syndrome. So we have to be careful to make sure that people are not getting deficient in B12. In the United States, the recommendation RDA is 2.4 micrograms. I will use 250 to 500 micrograms or more, depending on the patient, because I'm finding substantial deficiencies. With regards to chromium, it's a trace mineral that potentiates the action of insulin by binding to the insulin receptor. Diets high in refined sugar increase chromium excretion by up to 300% in some people. So I find it's important to have that in a good quality multivitamin. I do like this particular product, the Pure Lean Nutrients, because it contains all these and several others, as we'll see in just a moment. With regards to biotin, it's another B vitamin that's critical for carbohydrate metabolism. Biotin induces an enzyme, glucokinase, in a manner similar to insulin. And in a double-blind study of using 2 milligrams per day along with chromium, this lowered fasting glucose and hemoglobin A1C in overweight or obese diabetic patients. So I like the fact that both of those are part of the Pure Lean multivitamin. Alpha-lipoic acid is also present in the Pure Lean Nutrients, although it also can be bought as a separate and added at higher levels if we need to. But it's an insulin sensitizer, mitochondrial cofactor, and antioxidant. And there have been studies that show that it improves insulin sensitivity in patients with diabetes, and it helps reduce body weight in obese subjects. This study here, 4 weeks of alpha-lipoic acid, 600 milligrams twice a day. We'd need a higher dose. I think the Pure Lean Nutrients contains 300. But impressively improved insulin sensitivity in diabetic patients in terms of glucose disposal rate to the level of normal controls. We also find that we use higher levels in our patients who have diabetic nephropathy or neuropathy, nerve issues. Cinnamon is also a nutrient that actually has insulin sensitizing effect. A study that I found actually using a gram of cinnamon improved hemoglobin A1C by 0.83%, which is really great because some medications cannot do that. Green tea is something that has thermogenic flavonoids called catechins, ECGC, and it also helps increase energy expenditure by 4% compared to placebo. In studies, green tea catechins decrease body weight, waist circumference, and body fat mass. Some pretty impressive studies that showed that groups that use green tea lost more than those who were not using it, with everything else being the same. This particular product, Metabolic Extra, contains berberine and resveratrol. Resveratrol promotes healthy AMP kinase and SRT1, which is the same thing that exercise does. And that actually helps support cellular metabolism and glucose homeostasis. So in a randomized trial, a 4-week study showed it supported healthy insulin sensitivity and antioxidant defense. And berberine is also an AMP kinase activator. It enhances the expression and function of insulin receptors. So in this study, it showed that it statistically significantly supported glucose, lipid, and triglyceride metabolism. So I've been using this product in my practice for years. It is actually one of the most successful ones that I use. Interestingly, berberine has been extensively studied in Chinese medicine, been used for years and years. It's more new in the United States, but a lot of the studies about glucose metabolism has been done actually in populations in China using the Chinese herb name of berberine, but we have found it very, very useful. And we've had patients who have been on our weight loss program who we have added it to, and we've seen improvements in their lab parameters, or people where they've lost weight, but they still have evidence of insulin resistance, and adding this in has been useful to us. So just to review some of the famous favorite products, is this Metabolic Extra, the Pure Lean protein powders, Pure Lean Nutrients is the multivitamin, Pure Lean Fiber, I use magnesium glycinate, B12, it can be liquid. I also use a lot of something called adenosyl B12, which is a small capsule. vitamin D in various forms. The dose I use depends upon the amount of deficiency, and we follow levels. Same with the magnesium. And then I use a fair amount of 1-omega because many of my patients have high triglycerides, low HDL, and this is also very helpful. Talked about that already. We'll just move along to some case studies. So I have 4 case studies. We'll go through them because it might be helpful to see how we treated them. So the first case study, this gentleman, Rex, he was 66 years old, a retired pilot. He had a diagnosis of sleep apnea since his 50s, high cholesterol, and a coronary calcium score of 290, which is high, showing that he has some heart disease, some atherosclerosis. He was on medication for blood pressure. He was on medication for low thyroid. He had borderline diabetes by history and something called SVT, supraventricular tachycardia, meaning he was having extra abnormal heartbeats. He also had low B12 by history. When I saw him, he was taking aspirin, something called a beta blocker. This losartan is medication for for blood pressure. Metformin for his pre-diabetes, it's a medication. Thyroid medicine. He was on an acid blocker, which we know is going to lower B12 further, and atorvastatin for cholesterol, and he was on B12. So he described that he would have cereal for breakfast, a sandwich for lunch, meat, potatoes, and pasta for dinner. This is a standard American diet. He was also drinking fairly heavily, up to 4 drinks of 7 and 7, which is a hard alcohol and soda every night. He said he was always hungry. He had a very high BMI of 37.8. He was 252 pounds, but he was very overweight. But importantly, his waist circumference is 51 inches. That is very, very large. He has very significant abdominal weight. When we did his lab work, we found out that he was not pre-diabetic. He was absolutely diabetic. His blood sugar was 167. Hemoglobin A1C was 6.4, which is just under the cutoff for diabetes. Despite his B12, he was still deficient at 393. We've included some Canadian values or metric values. I'm not sure which ones you guys use, but just very low B12, very high triglycerides. So a level of 639 is extremely high. Triglycerides should not be higher than 100, so this is 6 times the level. His good cholesterol was exceedingly low, 24. It should be 55. His LDL wasn't too bad, but he's on a statin medication to lower. His magnesium in the red blood cell at 3.9 was very low. At the minimum, it should be 4.2, but it ideally should be above 6. His thyroid stimulating hormone showed that his thyroid was not well controlled. He was still hypothyroid. And this is an example, his fasting insulin. So his insulin before he's eaten anything in the morning is 19, and it should be 6 or lower. So in the morning, his body is acting like he's just eaten. So what we did with him was we started him on the MD Factor meal plan. We gave him a multivitamin, magnesium glycinate 3 per day. We gave him the purely nutrients. We gave him B12. We increased his dose of thyroid hormone. We want to improve as many parameters as we can. In a very brief period of time, 7 weeks, he had lost 25.5 pounds, which is a substantial weight loss. But he really stuck with the meal plan. His diet before was terrible, and he made these improvements. But what's huge to see is the improvements on the metabolic parameters. So his cholesterol has substantially dropped, probably too low. He needed less statin at this point. But a huge improvement of his HDL going from 24 to 32. Triglycerides going from more than 600 to 70. That's huge with the meal plan and a multivitamin. His glucose went from 167 to 96, so phenomenal improvement. Improved B12 into the normal range. Magnesium RBC was just normal, not great enough yet, but its fasting insulin went from 19 to 3. So huge improvement in metabolic parameters after a brief period of time with correcting the vitamin and mineral deficiencies and getting him on the right meal plan. After several more weeks, so at this point he's 20 weeks into his program, he had lost 43.5 pounds. His weight was now 208. His glucose had rebounded a bit. It was 115, but still pretty good compared to where he started. Importantly, his hemoglobin A1C, that's his 3-month blood sugar, had gone from 6.4 to 5.1. We had gotten him off of metformin and transitioned him to metabolic extra because he continued to drink alcohol, and metformin and alcohol interact. So we thought this was much safer for him. His vitamin D was improved, his B12 was good, his magnesium was actually getting better. And importantly, on magnesium, all of his palpitations stopped. Initially, we had increased his metformin, but got rid of it. Instead, used berberine, and were able to get these nice improvements, the metabolic extra with the hemoglobin A1C. And he never needed any medication to help with appetite or an appetite suppressant. We did this all with nutrients. And his cardiologist was quite impressed. He didn't think that was possible for a man his age, and of course it is. Let's see. Okay, next study. So Sherry's a 70-year-old woman. She had had weight issues in her 20s, never lost the weight after pregnancy. And by the time she came to see me, she had already had the diagnosis of diabetes for at least 20 years. And she had had a weight above 200 pounds for at least 10 years. She had been on the medication metformin for years. She was on an injectable medication called Victoza. Something called Invokana was added more recently. So she's on 3 medications for diabetes. And her most recent hemoglobin A1C at 7.4 showed poor control of her blood sugar. She was on medicine for cholesterol, and she said she felt like a carbohydrate addict. If she eats high carbohydrate food, she can't control herself and can't stop eating it. So when she started with us, she had a very high body mass index of 41. Her lab work showed that, okay, cholesterol doesn't look so awful. She's on a statin, but again, her triglycerides are too high. They should be less than 100. Her thyroid levels looked okay. Glucose is terrible, 167. Hemoglobin A1C, 7.2, not good. Vitamin D was fine, B12 low again. We want this level to be about 800. Her insulin in a fasting state, even though she's diabetic, is still above normal. But we're definitely seeing that her pancreas is starting to decrease the production of insulin. Her magnesium was okay, not perfect, but okay. So she started the meal plan and accountability. And even in a short period of time was able to lose 15 pounds, getting her glucose under control. Within 2 months had lost 25 and a half pounds. And again, we're comfortable working with aggressive weight loss in our program with our patients because we see them every week. We do intensive dietary counseling and figure out what works, and we're monitoring their lab work parameters. You'll see here that, even just a few months into it, her glucose is improved. Her hemoglobin A1C is 6%, a big drop from 7.2. In June of 16, she had lost 44 pounds, and she said she wanted to stop her statin. Her doctor didn't agree. In the U.S., taking a statin when you're diabetic is considered the standard of care, but she felt she was having side effects. She didn't want to take it. With stopping the statin, her cholesterol essentially was kind of like it had been on the statin. Her triglycerides were better. Her HDL was actually better, but her LDL was 130, and it was like 138 on the statin. Her chemistry was normal. It means her glucose was normal at 99. Hemoglobin A1C 5.7, much improved. Her internist said, restart the statin. She said, I'm not going to do it. Then it's like, okay, well, then you have to take metabolic extra. Let's get you to take 3 per day. That's the resveratrol berberine product. Continued to lose weight, lost 54 pounds. Several months later, 67 pounds. At this point here, probably a year, a little bit more than a year into her program, she's lost 70 pounds. Lab work looks phenomenal in terms of her glucose. She remains off the statin. Her LDL is 100, glucose 95. Hemoglobin A1C 5.4, normal vitamin D. B12, I'd like it better, so I'm going to boost her some more with that, but substantial improvement in a complicated patient on a lot of medication for diabetes. Jerry is a woman, 57 years old when she entered our practice, again, very overweight, body mass index of 42. She had some elevated blood pressure, and she had been overweight since childhood. Dieted in high school. Her weight crept up over the years. She did liquid diets, took diet pills. She was diagnosed with underactive thyroid in her 30s, then went through menopause, never took hormone therapy because she had had a blood clot in her 30s, and her weight just kept going. She had lots of chronic sinus issues, eczema, which makes me think of allergies, Her blood sugar was 101, and a doctor at some point in the past had put her on metformin for her elevated blood sugar, but it caused her all types of stomach issues, so she didn't take it. Now, I like this study because it shows subtle insulin resistance. So if we look at this, her blood sugar is normal, 91. Hemoglobin A1C of 5.2 is normal. I don't know if that means anything to you guys if we have the same values, but she's definitely not diabetic or pre-diabetic based on her 3-month blood sugar. Her cholesterol is like all right, but her good cholesterol is kind of low at 43. Her triglycerides are elevated above 30. So she has two things that show she has insulin resistance. Her bad cholesterol is fine. Her vitamin D is exceedingly low at 8, super low. Her B12 is too low. And then her insulin in the fasting state is 15.5. As I mentioned somewhat earlier, should be below 6. So she has 3 markers of insulin resistance. The HDL, the triglycerides, and the insulin. Her magnesium was okay. She was on medications for allergies. That's what Allegra and Flonase is. She was on medicine for thyroid and a prescription brand of vitamin D, which is vitamin D2, which we see she's not getting her vitamin D3, which is what she needs. So we put her on the MD Factor meal plan, get her on the Pure Lean multivitamin. We actually increased her vitamin D3 to 50,000 IUs, and of course we monitored that. Put her on B12. We put her on a probiotic because of her allergy issues. And what we found that she had nice improvements. Even in a few months, she had lost 14.5 pounds, but importantly said within 2 weeks, her cravings were gone, her intense cravings due to the fluctuations of her blood sugar. A few months later, we see her cholesterol profile looks a little better. The HDL hasn't increased that much. Triglycerides haven't come down that much. Insulin's better, B12's better, but we continue to monitor her. We were able to replace her vitamin D, got to 59, thought that was wonderful. We stopped the high-dose vitamin D and then just continued her with the Pure Lean multivitamin that has 2,000 IUs, added some calcium KD, which is also a pure product due to a history of osteopenia. So she's getting about 3,000 IUs a day. We started Metabolic Extra, again, the berberine and resveratrol product, to see if we could improve her cholesterol further. She had some bumps in the road. She was diagnosed with a deep vein thrombosis that ended up showing that she had a genetic clotting condition, needed something called Xarelto. We continued to see that her cholesterol was better. Vitamin D was looking a little bit lower, so we added a little bit more. Continued to lose weight, nice improvement in sugar. Hemoglobin A1C continues to be good. Cholesterol's good. Insulin's now 3.7. She has maintained her weight until this time. We're in now 2018. She continues to come to the practice with some regularity. Comes at this point like every other week to maintain her weight. She's continued to have some issues with her thyroid. We found out that she has autoimmune thyroid issues, so we're working on that. So she was able to achieve a substantial weight loss, 86.5 pounds, which are some of the levels you would see with a surgery. Now, of course, she didn't have any surgery. This was working with nutritional parameters. And then just last one, case study of David, who's 75, had weight gain over his lifetime, very busy and stressful job. When he retired, he actually gained an additional 40 to 50 pounds, had his knees replaced, he had a history of kidney stones. When he entered, he was on blood pressure medicine, medicine for cholesterol, medicine for his prostate. He did not have known heart disease, but he did have sleep apnea. And again, just to see the subtle insulin resistance, his glucose was abnormal at 106. His hemoglobin A1C was above ideal. We consider anything higher than 5.5 abnormal, so it's showing his 3-month blood sugars elevated. His D is only mildly okay. Magnesium is low. His cholesterol was okay. He's on cholesterol medicine, but his fasting insulin was 24.9, so essentially 4 times higher than normal in the fasting state. He's secreting so much insulin. Low B12, his thyroid was kind of borderline. But what he said to me is, I feel like a carbohydrate addict. You know, he was almost 300 pounds. And he said, I've been so successful in my life, but I can't control these cravings. I feel I need like this very, very strong medicine for carbohydrate, like for addiction. And we talked about, well, let's follow the meal plan and see what happens. Like he thought he was powerless over food. But it's like, well, let's see if we can improve the insulin resistance, improve this compulsive eating. He was in his 70s. I did not feel comfortable that he should take a medicine that contained amphetamine to help with his compulsive eating thoughts. Instead, he did a meal plan for insulin resistance, took the purely nutrients, took magnesium glycinate, fish oil, B12. He, again, had very nice results. He met with a therapist regarding binge eating disorder and reported that on the meal plan, he no longer had thoughts and behaviors consistent with binge eating disorder. He had lost 20 pounds. His weight's coming down, it's 260. Cholesterol looks a lot better. B12 still so low, so we boosted him up to the 2,000 IUs. That's the adenosine B12. His thyroid's looking better. His insulin had dropped to 7.4 from 25. Kept going, stayed with his program, lost 45 pounds, lost 53 pounds. Blood sugar, again, looking better at 5.5. The lipids are looking okay, but not perfect. I want the HDL better, the triglycerides lower. So we increased them to 2-3 times a day of his metabolic extra. Left for the summer. A lot of our patients are seasonal. But when he came back, he had lost 85 pounds. He continued on his meal plan. All of his parameters look improved. His hemoglobin A1C, 5.3. Magnesium looks great. Thyroid, B12. Insulin, 5 instead of 25. Vitamin D. And what he said is, I'm free for the first time in my life from sugar cravings and the self-disgust I lived with, because he was really so disappointed in himself with the weight. So correcting a metabolism that does not work properly is life-saving. Importantly, symptoms respond, and there are symptoms, within 1 week of the meal plan, maybe 2 weeks, but that intense hunger and craving is gone. And the bottom line is it's very hard to lose weight if you are starving and hungry. You can have good willpower, but the body will win out. If it is starving internally, you will eventually eat those foods. You will eat the sugars. Blood pressure, cholesterol, all the markers of abnormal metabolism get better. Sometimes they normalize. Sometimes it takes longer than 6 weeks, but I've identified several case studies where there was significant movement towards normality over the course of time. And in our practice, we monitor that. We support our patients with nutritional and behavioral counseling, but also monitoring the effects of metabolism so people can see it. So metabolism correction is really essential to keep lost weight off long term. I think what happens to so many people who have insulin resistance is they lose weight, but their insulin resistance never gets better. And if the insulin resistance does not improve, we saw from a couple of the cases where, this part is a lot better, but their A1C is still higher than it should be. Their triglycerides are still higher. By adding the other supplements and the other things, we can push it down, get those levels even better controlled. Because if there are drivers for the body to crave sugar, crave carbs, store fat, weight regain will be inevitable. And then, of course, making sure in the weight loss process that weight is being lost from fat, not from lean muscle tissue, which will adversely lower metabolism. That's also important. So we primarily correct metabolism through the meal plan, correction of vitamin and mineral deficiencies, exercise, supplements. And I will say I am a medical doctor. We might use medications if that is not enough in its own. Sometimes we need more help. But by doing the totality of it, we find that it's great. And many of my patients have said, this is the best I felt in 30 years or 50 years. And that, of course, is very empowering and a great reason to continue doing what we do.